Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor. We're here this evening with Dr. Raymond Phillips. He's a practicing gastroenterologist in Naples, Florida. He practices with the Gastroenterology group of Naples, and you have 4 or 5 gastroenterologists?
There's a total of 5 of us together, yes.
And we will be talking about GERD, gastroesophageal reflux, acid reflux, and esophageal cancer.
Well, Dr. Phillips, why don't you just introduce yourself? I know you've been on the show several times, but maybe we have some new viewers that...
Oh, sure, Jim. Yeah, let me just give you a rundown what a gastroenterologist is. And that's what I am, a board-certified gastroenterologist. I went to a college. I graduated from Princeton University, cum laude. I went through college on an ROTC scholarship, and I'll come back to that in a little bit. But after I went to Washington University in St. Louis Medical School, and then I did my internal medicine training at Jefferson Hospital in Philadelphia, and I was chief resident there for a 4th year. When I concluded that training, the Army remembered where I was, and they brought me back on active duty, and they sent me to a place called Fort Leonard Wood, Missouri. And that's where I served as an internist, an adult internal medicine doctor for 2 years. And then I was selected for gastroenterology training, and I was trained at Walter Reed Army Medical Center for 2 years in gastroenterology. And then subsequent to that, I was selected to be on staff at Walter Reed, where I spent an additional 2 years being on the professional staff. In 1991, after the first Persian Gulf War, my obligation was complete, and I entered the civilian life, and I came down to Naples, where I've been practicing ever since. And I practiced with Dr. Lubersky, Susan Lubersky, Neil Randall, Michael Marks, and Ahmed Khatib. And we have offices in Naples on Goodlet Road, as well as satellite offices in Bonita and Marco Island.
Well, then do tell us what a gastroenterologist does
before
we get on to acid.
Well, a gastroenterologist in its essence is a tummy doctor. And not to diminish what we do, because it's a broad range of issues that we deal with. The Army particularly emphasized gastroenterology because that's one of the major symptoms that troops suffer with or lead to disability with on active duty. That is to say, gastrointestinal issues. In particular, over the course of thousands and thousands of years, issues in terms of gastrointestinal illnesses like diarrhea were the major causes for armies not failing on campaigns. So there's been a great emphasis in gastroenterology in the context of the Army, and all the way from well, anyway, a great emphasis on gastroenterology. Now, as a gastroenterologist, we deal with problems all the way dealing from issues relating to taste, as well as consuming food, digestion, and as point of digression, we're the only specialty that's specifically trained in nutrition and digestion. It seems like when you watch TV, all the doctors on TV want to be gastroenterologists because they talk about nutrition, they talk about digestion, but we're the only specialty that's specifically trained in that. But more to the point, we deal with all gastrointestinal issues from the mouth all the way to the very end of your GI tract, as well as issues associated with the pancreas, the gallbladder, and the liver. So it's a broad range of topics, many, many different areas of interest that are very exciting. But today, we were actually turning our attention to one of the most common symptoms in the United States, the issue of heartburn, and how that particular condition can lead to substantial side effects and consequences that also have medical attention. In particular, the one that has gotten our most attention recently is the increasing association between heartburn and the formal name for heartburn. That's actually one symptom, but the overall condition is called gastroesophageal reflux disease, where stomach contents, instead of remaining within the stomach, reflux up into the esophagus. And the normal circumstance when you swallow food is that when you chew and swallow food, as it makes its progression from your mouth through the esophagus, at the point where the esophagus joins the stomach, there's a valve that opens to allow passage of food or liquid into the stomach. and then that valve closes shut to prevent backwash or food or fluid from the stomach up into the esophagus, but also to contain or keep acid in the stomach itself. But when that valve does not function well, when it relaxes or it's inefficient in terms of its function, acid in the stomach can wash up or reflux up, which is the formal scientific name, up into the esophagus. Now, the lining of the stomach is specifically designed to tolerate acid. Just remember in your high school chemistry, as you recall, acid is measured on a pH scale from a pH of 1, which is extremely acidic, to a pH of 14. And a 7 is neutral. That's close to what the pH of your bloodstream is. And so your stomach has a pH of 1, and it'll maintain that pH throughout your entire lifetime. And as I said a moment ago, your stomach is well designed to tolerate that degree of acidity, but your esophagus is not. And so if you get in that circumstance where this valve that separates the esophagus from the stomach is not working properly, acid washing up into the esophagus will literally burn the esophagus and create an injury. So when you feel a burning, it is burning your esophagus.
It also can be silent.
Well, and that's a key point. And heartburn, I said that several times, it is a burning sensation you feel in your chest radiating up to your throat. But there are many, many other symptoms associated with reflux disease. And for years, we just focused in on the obvious things and sourness, but there can be many, many other symptoms that are not as apparent. Symptoms such as clearing of the throat as a result of irritation to the back of the throat, change in quality of the voice as a result of injury to the vocal cords, or hoarseness or raspiness to the voice. Sometimes polyps on the vocal cords, aggravation of asthma, development of sinus infections or sinus inflammation. Other things such as chest pain or issues in terms of a lump in the throat, or a chronic cough. These are all symptoms that are particularly distracting here in Florida, because some of those same symptoms are symptoms you see in the context of someone who has allergies. 80% of Floridians have allergies to something in the environment because of the different things that are growing in the environment. And many of the same symptoms I've mentioned, sinus inflammation, clearing of the throat, cough, are the kind of things, sensation of postnasal drip, are the kind of things that you see with allergies. So there are many, many other symptoms that have come under the designation, quote unquote, silent, but nonetheless are related to reflux. But so we've come to have a broader understanding of the nature of reflux, and increasingly we've realized that there's a large proportion of the population has reflux on a fairly regular basis. And those individuals are increasing concern. Just to digress, the market for treatment of heartburn or reflux symptoms, it's a $5 billion a year industry. When you include drugs from antacids like Tums or Rolate, no endorsement there, just mentioning the names, but to drugs such as Nexium and Prevacid and Dexilant and Acifex and Prilosec, these, and to say nothing of the forebears like Zantac and Tagamet as well as Pepcid. This is a gigantic industry, all devoted for the control of acid production within the stomach itself.
Does this affect different age groups or different, how does it affect different people?
Well, it does. It does seem to affect adults more than adults or children, and there are things that adults do that are not well considered in terms of increasing weight, for example. Increasing weight promotes reflux.
Okay.
So if you store a lot of fat in your abdomen, there's less room for the stomach to expand, more pressure on the stomach, and more of a tendency to have reflux from the stomach to the esophagus. So the growth of America and the growth of individuals in particular has led to increased problems with reflux. So there's a direct correlation with obesity. The other point is that adults tend to eat more, and as a result of greater volumes of food, that can promote reflux. Certain foods that taste good will promote reflux, and what I mean by that is that when you eat food that is particularly tasty, typically it has a high fat content, and that fat promotes reflux because it relaxes that valve and allows stomach acid to flow more easily up into the esophagus. So the kind of foods that are enjoyable, you eat a lot of them, and then the stomach takes time to empty. If you eat foods, it typically, a rich meal takes 2 or 3 hours to empty. Well, the nature of America is such as people work late, they eat late, they're tired, they go to bed, and there's not sufficient time for the stomach to empty out. And then when you're horizontal, you no longer have gravity to help hold things in your stomach. And there's a tendency to have a nighttime reflux that can be very, very troublesome.
So you're saying the later you eat, it might not be as good for you.
Well, precisely, and that's the nature of living in Naples.
Right.
You know, the individuals, they socialize, they go out to dinner, they have a nice dinner, they eat foods that promote reflux. In terms of a rich meal, alcohol, chocolate in particular promotes reflux.
Right.
You finish the meal with a little mint, which is an Arabic custom that promotes relaxation of this valve, so you can have a discrete burp at the end of the meal to express your pleasure at the meal. And this was very common in Arabic cultures in the 700s and the 800s, and it's continued now. But that mint promotes reflux as well. And then you go home, lay down, and then you reflux because you don't have gravity to help hold things in your stomach. So there's a number of different points, different issues that can promote reflux. And it can cause a lot of symptoms, like we've talked about, but it actually can cause a physical burn to the esophagus. And because of that injury to the esophagus and the consequences of it, we're realizing there's a connection between reflux and the development of esophageal cancer. And that has received increasing attention now because the rates of esophageal cancer have been rising in the last 20 years. It's the only cancer that we follow that is actually the rates have been increasing over these last 20 years, almost tripling over this last 20 years. And the sequence of events is as follows, is that reflux of acid leads to a literal burn of the esophagus. And as we were describing, the linings of the esophagus is in layers. And it's the innermost layer that gets burned away. And when it gets burned away, the esophagus develops a new layer that can better resist acid, and it's called Barrett's esophagus. And that Barrett's esophagus, although protective to the esophagus, entails some risk because that Barrett's esophagus sometimes can develop cancer cells that can mature into full-blown esophageal cancer.
We will take a short break,
Okay.
just for a few minutes,
All right.
and we'll come back to talk with Dr. Phillips in just a few minutes.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation through the cancerous areas. Fast. Each treatment is only 1 hour and invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Welcome back to Dialogue with the Doctor. Once again, we're here this evening with Dr. Raymond Phillips. He is a practicing gastroenterologist and a very good one in Naples, Florida here. We're talking about acid reflux, esophageal scarring, which is called Barrett's esophagus. And we just got finished, Dr. Phillips just got finished describing what that is. Causes scarring and makes a new layer.
Yeah, let me recap that for you. And first you need to understand the esophagus, and the whole GI tract for that matter, but we'll just emphasize the esophagus, is developed in layers, like layers of onion. And it's the innermost layer of the esophagus, which is the one that can become injured as a result of reflux of acid. And that innermost layer can literally be burned away, and when it's burned away, the esophagus develops a new layer that's capable of resisting that acid. And that condition was discovered by Dr. Barrett in the 1950s, and it came to hold his name over the years, called Barrett's esophagus. Now you need to understand, that's a kind of rare event, Barrett's esophagus. And it only happens in people who have severe reflux symptoms. And severe reflux symptoms are individuals that are having heartburn 3 to 4 times per week, not someone who's having it every now and then. So if someone that has heartburn 3 to 4 times a week, if you take 100 of them, individuals with that kind of symptom, maybe only 10 of that 100 will develop Barrett's esophagus. Now, if you develop Barrett's esophagus, as I said before, it's a new lining you were not born with, but it does protect the esophagus. It has a slight potential of evolving into a cancer of the esophagus. And that's a rare risk, but a real one. So if you take 500 people with Barrett's esophagus, maybe one of them in the course of a year's time might evolve into a cancer of the esophagus. So the risk is rare, but nonetheless, it's a risk. And so we've cautioned people who have had bad heartburn that it would be worthwhile to consult with your doctor and to control the heartburn and to perhaps be evaluated to see if there's any sign of any injury, and particular to see if there's any sign of any of this condition called Barrett's esophagus. Now, you might say, well, what would you do about it if you found something like that? Well, if we found Barrett's esophagus, we do biopsies to see if there's any microscopic changes that might put you at risk for cancer of the esophagus. And for years, that was all we could do, was to come back periodically, check, see if there was any sign of that. And if it looked like there was developing cancer cells, the response would be, yes, let's remove the esophagus. A very, very large operation associated with significant mortality, a lot of morbidity. But several years ago, a new technology was developed that now allows us now an alternative approach for treating this condition. So again, the condition is if you have Barrett's esophagus, and if you've done biopsies and identified developing cancer cells, again, that's a rare event, but if you identify developing cancer cells, now there's a way of treating it that does not involve an operation. And what can be done is that there's a way of actually applying heat to the innermost lining of the esophagus and essentially burning away that lining. And by burning away that lining and then taking medications to reduce acid in the stomach, when that lining regrows, it resets itself back to normal. That is to say, it develops a normal lining once more. And the Barrett's esophagus is at least in the preliminary studies that we followed now over several years, is eliminated permanently. So we've been very excited about this because now we have a means of being able to, if we find an individual with Barrett's esophagus, we identify developing cancer cells, now we have a means of treating that without subjecting that individual to an operation of the esophagus. And we've gotten very, very excited indeed about that because it represents a great innovation and means of being able to provide care without inflicting a lot of injury and harm to individuals. Now, let me digress for a moment. A lot of people say, well, Dr. Phillips, I'll just take something to reduce acid and that'll make a difference. By itself, that will not make a difference. Hundreds of studies have been done now investigating, controlling reflux and whether that will make Barrett's esophagus go away. It won't. It remains unchanged for the most part. So this is the only technology now that we have available, intervention that we have short of an operation to eliminate the Barrett's esophagus and to actually prevent a progression from a cancer cell to a full-blown cancer.
Is that procedure reserved for patients who have a biopsy that's abnormal, or do you do that on all patients with Barrett's esophagus?
And that's a key point, Greg, is that we reserve that treatment not for all people with Barrett's esophagus, but rather instead those individuals in whom you do a biopsy and you show a developing cancer cell. This intervention is specifically for those people because, as I said before, the majority of people with Barrett's esophagus will never go on to develop anything serious. And so you don't need to subject all those people to a treatment and when the risk of developing something serious in the future would be very, very small.
Do you have to keep biopsying? Or if somebody has a negative biopsy, do you have to wait 5 years and do it again? Or
well, that's a key point. And that's a key point, is that Barrett's esophagus, you do need to do biopsies periodically. Initially, we'll do an initial set of biopsies that are very thorough. And then if no sign of developing cancer cells are present, we'll come back a few years later and do it once more. Much like when we do colonoscopies on individuals who have polyps, if we do an examination and remove a polyp, we know they have a tendency to form polyps, we'll come back at an interval perhaps 5 years later. For an issue of Barrett's esophagus, if we do a biopsy, confirm the Barrett's esophagus, but they have no sign of any cancer cells, yeah, we'll come back in 3 years' time to do a further set of biopsies to look to see if any changes over that interval.
If I send you a patient who has acid-related symptoms, who do you biopsy? Or who do you scope? You don't scope them all.
No, and because that would be half the United States. That'd be too much. That'd be too much to do. So what we do is try to identify. We try to select individuals that have significant reflux, and what we define as significant reflux is an individual that's having heartburn 3 to 4 times per week, and individuals that has had that for a period of time. I'm not talking about someone who went on vacation on a cruise and attended every dinner meeting at the cruise and then had heartburn the whole cruise long. I'm talking about someone who's had heartburn on a weekly basis for 2 to 3 years and having on a weekly basis, having it several times per week. That's how you can select out individuals who may be at more risk.
So even if that patient came in to me and I treated them with an antacid, made their symptoms completely go away, that person should be scoped?
They should, if they can recall a time when they had significant heartburn and reflux and it was going on and on
Yeah.
for years and years, and then they finally encountered you put them on effective therapy, and the heartburn went away, but they remember, gosh, for 5 years before I saw Dr. Leach, things were just terrible. Then yeah, they would probably deserve at least one examination of the esophagus to be confident that they didn't have any sign of Barrett's esophagus. So.
You can scar the esophagus too. Occasionally we send you a patient who you have to open the esophagus or dilate the esophagus.
That's true, and we've been dwelling on the issue that when you have reflux and it causes an injury, it can burn away a lining of the esophagus, but sometimes it doesn't. It just burned, and then the burn heals. And just like if you get a burn on your skin, it forms scar tissue, the same thing can occur within your esophagus, is that when you get a burn in the esophagus, it can lead to scar tissue. But the nature of the esophagus, it's a cylinder. It's a round structure. So when you form scar tissue in a circle, it tends to constrict and narrow the diameter of the esophagus. Because if you notice, if you've ever cut yourself, the edges of the wound are pulled together, and they're pulled together because of scar tissue that's forming within the wound. But when you form scar tissue in a circle, it tends to like increasing narrowing of the esophagus. And then foods that have more substance, like meat or bread and so forth, can come to that narrowed area and get stuck. And those individuals, they need a different intervention. They actually, as you described, need to have the esophagus dilated to stretch out that scar tissue so food doesn't get stuck at other times.
So given that we have a $5 billion industry of antacid sales, we have these over-the-counter, Prilosec and Prevacid are over-the-counter. They're excellent acid blockers. So a patient can be treating themselves without seeing a physician, which in a way is good, but in a way is not good if they haven't been properly examined. How do you?
Well, and that's an issue, and that's why the FDA, when they approved these drugs for over-the-counter use, they put these frightening warnings on Prilosec OTC as well as Prevacid that do not use beyond 2 weeks because you've got to see a doctor after 2 weeks. Not because the drug is dangerous, it's because the drug is so safe and effective. The concern of the FDA was just precisely what you said, Greg, is that an individual would hit on the medication, successfully treat themselves and say, well, why do I need to see a doctor? And they could self-medicate themselves and have put something potentially serious that needs attention. So, for example, in the context of, say they had an ulcer they were self-medicating and treating, well, the ulcer can come back again and again. That individual needs to be evaluated to see if there's any sign of an infection called Helicobacter that may be provoking that ulcer. And in this context, if there's an individual with bad reflux, they need to be evaluated to see if they had any complications from that reflux, like Barrett's esophagus. So the notion is that that warning was that if an individual is finding they're having to use medications like that on an ongoing basis, yeah, they probably do need to see a doctor to be more completely evaluated. And so, yeah, it's a little bit of a. We've had great success with these medications. They're so effective, and they're so safe. Now they're available on a widespread basis, and so it's a caution to patients everywhere that, yeah, if there is heartburn that's been regularly and you're regularly trying to treat it, yeah, it probably does deserve some an evaluation.
And if they need to be scoped, it's not like a colonoscopy. It's much easier to put a scope.
Well,
in
precisely, and doing an examination of the esophagus, again, we provide sedation so you won't even know the examination has been done. The preparation is straightforward to the extent that you just don't eat any breakfast. You won't even know the examination has been done. The anesthetic now is so effective, and so it can be a very, very good experience. So the upshot of talking about reflux or gastroesophageal reflux disease in general is that there's a number of different manifestations. There's a number of different complications. We talked about Barrett's esophagus and the association with cancer of the esophagus. We talked about scarring in the esophagus. But the notion is if there's chronicity to the heartburn or reflux symptoms, it does deserve evaluation at least once. And now there is a prospect, a very real prospect, of being able to prevent serious consequences, like cancer of the esophagus, if an individual can be evaluated in a timely way.
I want to thank you, Dr. Phillips, for coming this evening.
Sure.
And educating us once again.
Thank you very much.
Well, thanks for having me. I appreciate it.
Yep.
All right, thanks so much. Thanks,
you.
Jim. Thanks.